You are now listening to Nailed It, the Orthopedic Surgery Podcast.
All right, everyone. Welcome back to a Citations Classic shoulder and elbow edition. Today we are going to be talking about distal biceps rupture. I am Sam Fuller. I'm here with a few of our team members. We've been trying to get this episode out for a while now, but unfortunately I've been on nights for the past 10 weeks, and then Dr. Macfarlane couldn't join us today because he had a late case as well. And then other members of the team, all very busy, but we want to bring this to you sooner rather than later. And then I also apologize for my voice. I was at the Bills game, big win for the Bills, go Bills. But today we will start talking about some distal biceps rupture. So a little bit of intro. The biceps is essentially two main heads. There's the short head and the long head. The long head inserts on they both insert on the radial tuberosity. The long head inserts more proximally, and the short head inserts more distally. The two main motions that this controls is supination as well as flexion. And so going along with that, that's some of how we can test to see if there's a rupture of this. So one good test is the resisted supination. Another test that we can do clinically is called the hook test, where you take your index finger and try and hook under the tendon distally in the antecubital fossa. If that is abnormal, meaning you can't hook anything, that is indicative of a tear. But you can have some false positives where you think you're hooking something. It could either be the lacteris or it could also be partial tear or brachialis. So that's something to be wary of with these as well. If there's any, if it's not clinically apparent, you can always get an MRI as well. And then clinically, you can also sometimes see a reverse Popeye deformity as well with these. Without further ado, though, let's get into some of these articles that we have.
Thanks, Sam. So the first article we're going to get into is titled Complications of Repair of the Distal Biceps Tendon with the Modified Two-Incision Technique. This is an article by Edward Naw at Mayo Clinic, published in 2000 at the JBJS. So at the time, a little bit of background. Surgical approaches to the distal bicep ruptures have been controversial due to a variety of reported different outcome complications. Specifically with the anterior exposure, was associated with a high radial and median nerve palsies. With the two-incision technique, it was associated with proximal radial ulnar synostosis, as well as a posterior interosseous nerve injury. So the technique that they wanted to investigate was actually the muscle splitting modification of the posterior approach going between ECU and EDC. With this, they hypothesized that because it does not expose the ulna subperiostally and also does not go through the culture interval, it would not have as high of outcomes in terms of complications such as radial ulnar synostosis. So they want to describe the complications that they did encounter with this repair for bulged but distal bicep tendons. Overall, it's a retrospective study from 1976 to 1997 at a single institution. Patients that were included in this suffered a distal biceps rupture that was repaired using the Murray and all muscle splitting modification. And they did not use any tendon graft for any lengthening of the tendon. 74 patients were included. Average age was 46 years old, predominantly male. 73 of them were male, 1 female. They had 26 left biceps, 48 right biceps, 55 complete distal bicep tears, and there were 19 partial ruptures. The average follow-up was about 2.8 years. Different categories that they subdivided these patients in included time from injury to surgery. This was subdivided into 3 groups. The first group being the acute group, in which the biceps were repaired in less than 10 days. There were 41 patients. The second group being the subacute group, which the biceps were repaired in between 10 to 21 days. There were 16 patients. And the third group being the chronic group, in which the biceps was repaired greater than 21 days after injury. They had 17 patients in that group. The second category that they divided the patients up into was based on surgeon experience. Any distal biceps repair that was performed by a surgeon with more than 20 operations doing a distal bicep repair was considered an experienced surgeon. And they had 48 patients who had their distal biceps rupture repaired by an experienced surgeon. And any surgeon with less than 4 operations repairing the distal biceps was considered an inexperienced surgeon, and there were 26 patients total in that group. And so the different outcome measures they want to look at specifically were to compare the complications and complication rates between those subdivided groups. In total, there were 24 total complications of all patients. This accounted for 31% complication rate of the total study. The most common complication was anterior elbow pain, in which 6 patients suffered from. The next most common complications included a number of paresthesias, the first being 3 patients suffered from lateral antebrachial cutaneous nerve paresthesias, and 2 patients suffered from superficial radial nerve paresthesias. There was also 1 transient PIN palsy. There were 3 superficial infections due to suture abscesses. There were 4 minimal heterotopic ossifications. And there were 3 patients that suffered a range of motion loss greater than 10 degrees. 1 patient had a 30-degree loss of supination. 2 patients had a 20-degree loss of pronation. There was 1 bicep re-rupture. There was 1 transient reflux sympathetic dystrophy that resolved within 1 year. And there were 0 radial ulnar synostosis within this patient population. When looking at the complication rate and comparing acute versus subacute versus delayed repair group, the acute group had a total complication rate of 24%. The subacute group had a complication rate of 38%. And the delayed repair group had a complication rate of 41%. Again, the most significant and most recurring complication was anterior elbow pain. In fact, anterior elbow pain was significantly higher for those delayed repairs when compared to subacute and the acute repairs. There were 4 in the delayed group, 0 in the subacute group, and 2 in the acute group. There were no other differences in complications observed based on time to repair. When looking at surgeon experience, the average time to repair for experienced surgeons was 817 days. There were a few outliners that really shot up that average, and the average time for inexperienced to repair was 43 days for that patient, for their patient group. Overall, there was a 38% complication rate in the experienced surgeon group and a 19% complication rate in the inexperienced group. However, this difference was not significant, and there were no other significant differences found based off surgeon experience. So what this study showed and found was that a delay of more than 10 days before repair of that distal biceps tendon rupture was at an increased risk of complications. Patients who experienced anterior nerve paresthesias, who had a long Henry incision anteriorly, were also at an increased risk. Patients who did not have that long Henry incision anteriorly and had a small anterior incision did not suffer any anterior nerve paresthesias. This article also included that radial ulnar synostosis, if properly dissected, and as well as if there's meticulous irrigation of any bony pieces left inside, is very adaptable to not run into any radial ulnar synostosis complications following this approach. So overall, this 2-incision technique was found to be safe if best performed early, and with there being limited anterior dissection.
Awesome. Yeah, great. A great recap of that article there. Also, something that we probably should have mentioned in the intro was that a lot of these biceps ruptures, kind of like you mentioned in the intro of the paper here, is that they can be repaired through a single or a dual incision approach. And a lot of these earlier papers are looking at these different approaches and trying to figure out, are they safe and which one's better? And for a little spoiler alert, that debate still kind of goes on today a little bit. But that's going to be kind of looking at some of the things that we're looking at and the complications, whether it's synostosis or heterotrophic ossification, and kind of balancing those complications. And we'll see more of that as we kind of go on here.
Yeah. So it's kind of like Sam was saying, a lot of these articles focused a bit on the various approaches and fixation techniques. So the article that I reviewed was repair of distal biceps tendon ruptures with a endobutton fixation technique. This was published in JSES. So we already touched on a lot of the background for this, pretty similar to Jalen's article, but the early studies on biceps tendon repair used either a repair to the brachialis tendon. These demonstrated inferior results to anatomic repair to the radial tuberosity. And then between the two approaches, anterior or dual incision, posterior, there have been some issues with both previously. Prior to this article, the anatomic repair that was described required either an extensive anterior dissection, which was associated with higher rates of nerve injury, like we saw in Jalen's article, or just a very difficult technique to do through a small anterior incision to get the proper angle required to pass sutures and shuttle sutures through the radius to get the bone tunnel fixation that was previously used. And then the complications associated with a double incision repair being higher rates of HO and synostosis, which we already kind of touched on as well. So the purpose of this paper was to describe a new technique using endobutton fixation and report the results. So the authors of this study, they presented a technique report and then a retrospective review of 12 male patients, average age 38, and 11 of 12 of the biceps tendon ruptures that they repaired were acute. All of the acute repairs had direct repair, and then the chronic repair did have an Achilles allograft. So their treatment method, they used the single incision anterior approach through a small anterior based incision. They anatomically reconstructed the biceps tendon on the radial tuberosity, and then they fixed it using an endobutton fixation, which you can kind of see here in the figure over on the right. Their post-op protocol, they allowed mobilization after 1 week for gentle range of motion, and then no heavy lifting for 3 months. So pretty standard there. They also provided a cadaveric section of this paper as well, where they dissected 5 cadavers, and then they measured all of the major neurovascular structures surrounding the biceps tendon and radial tuberosity, and they measured the distance from the radial tuberosity. And then using a Steinman pin, they advanced this pin through the radial tuberosity at both 0 degrees and a 45-degree angle, and then measured the distance from the pin tip to the PIN, that's kind of the main thing with this technique. One of the main risks is transfixing the PIN after you go through the second cortex of the radius. So they wanted to look at an anatomic component to this study to determine what the best pin trajectory was for that. So their results, we can see the results of the cadaveric dissection here. The average distance from the biceps tendon and radial tuberosity to neurovascular structures are listed there in table 2, with the ulnar artery being closest and then the PIN being furthest. And then in table 3, this is where they use the Steinman pin, and after going bicortical through the radial tuberosity with that at 0 and 45 degrees, they measured the distance of the PIN to that, and it was significantly less at the 45-degree angle than the 0-degree angle, meaning that the PIN was closer at the angle using 45 degrees. Clinical results, they had no failures of the 12 patients. Mean flexion and extension arc was 5 to 146 degrees. Mean pronation of 80 degrees. Mean supination of 81 degrees. All patients regained 5 of 5 strength in both elbow flexion and forearm supination. And then they had one complication. It was an abscess formation that required IND, and was successfully treated afterwards with antibiotics. So in conclusion, this study did demonstrate the safety and the efficacy of the single incision endobutton technique for treatment of distal biceps ruptures. It does avoid complications associated with the other techniques of anterior fixation or using the dual incision approach. The one downside potentially to this approach and fixing it with an endo button, well, two downsides that they both mentioned in the ASES core curriculum video that Alex sent out. If you guys watched it, one of them would be if you're using that tension slide technique with the endo button, if you don't get your knots tied down securely all the way down against the far cortex where the endo button is flipped, you can get toggling of the tendon and it can loosen up. So that's one pitfall of this approach and technique of fixation. And then the other being if you end up erring anteriorly and performing a not perfect anatomic repair, then that has been shown to lead to decreased supination strength. So overall, a reliable technique as long as it's done technically sound and appropriately. And then the cadaveric dissection portion of this, they concluded that the safe zone was from 0 to 30 degrees when you're aiming that pin through the radial tuberosity to get your endo button fixation and to drill your tunnel, and that this minimizes risk to the PIN.
All right. Moving on to the next article titled Distal Biceps Tendon Repair Comparison of Surgical Techniques. This article was published in the year 2003 in the Journal of Hand Surgery, done by L. Harway and colleagues. So this is probably going to, continue on with what we've already heard, but just to provide some more background behind the thought process behind this article. In 1956, Fisher and Shepnick utilized a Voller-Henry approach to reattach the distal tendon to the radial tuberosity. And as we previously talked about, this was really crutched by the radial nerve palsy that could occur as a postoperative complication. And then, as we previously alluded, Boyd and Anderson developed this two-incision approach to better visualize the tuberosity, but once again, crutched by synostosis of the proximal radial ulna. Then Mori produced an adaptation of the Boyd and Anderson approach, but this also had the dorsal muscle splitting dissection that avoided the subperiosteal elevation and PIN injury, as Jalen talked about in the first article. And then, just as we kind of talked about recently with the suture anchor fixation with limited anterior approach, it's becoming a more preferred technique by surgeons. But ultimately, this article really wanted to look at the comparison of the anterior approach with suture fixation versus the Mori modification of the two-incision approach and prospectively compare the results and postoperative outcomes. So continuing out the study design laid out by these authors, this was a 4-year study period at a single institution, and they had a total of 19 bicep tendon ruptures treated acutely at a mean of 13.6 days by one of 3 surgeons. The study population was all men at an average age of 45.7, and the dominant extremity was injured in 12 out of the 19 patients. The treatment groups were as follows. There's 9 patients with a single incision limited anterior approach with 2 suture anchors for fixation. And then there was 10 patients with the modified 2-incision technique. And for those following along on the video format, table 1 shows the surgeon characteristics. And basically, for me to spell it out here, is that surgeon 1 did 5 single incisions with 0 2 incisions. Surgeon 2 did 4 single incisions and 2 double incisions. And then surgeon 3 did 0 single incision and 4 double incisions. So the authors then assessed the patients at 3, 6, and 12 months. And the outcome measures that they looked at included the SF36 and the patient-related rated elbow evaluation for patient rating scores. They also looked at the range of motion that the elbow could range to, as well as isometric strength, isokinetic strength, and elbow radiographs taken at the 3, 6, and 12 months. And so continuing with the results, In terms of the patient-rated elbow evaluation, there was no statistical difference between the two groups, including the 1 incision and the 2 incision. There was also no difference between the SF-36 scores at 3, 6, and 12 months. Now, looking at the flexion percentage, comparing the single incision to the double incision revealed that elbow flexion range of motion was significantly better in the single incision group at 6 and 12 months after surgery. We can see that it was 141 in the 1 incision group versus 128 in the double incision at 6 months, and then 143 versus 131 respectively, once again, in the 1 incision and 2 incision. And these results were found to be statistically significant. The authors also noted that there was no statistical difference between the extension, supination, and pronation. It was just as previously stated as the flexion degrees. The authors also noted that there is isometric elbow flexion strength was better in the 2 incision group at 3 and 6 months after surgery. It was 81% at baseline versus 65, and then 106 versus 85 respectively. So that was once again the 1 incision versus the 2 incision, and this was found to be statistically significant. The authors also noted that isokinetic elbow flexion strength was significantly improved at 6 months after surgery in the 2 incision group, and this was 108 versus 81, which was once again statistically significant. There was also no statistically significant difference in the flexion strength 1 year after surgery, and then there was no statistical differences in the groups supination, pronation, extension, range of motion, or strength at the 3, 6, and 12-month examinations. So continuing on to looking at the complications, the 1 incision group had 4 out of the 9 patients have complications at 44%, which is quite large. They had 3 patients with lateral antebrachial cutaneous nerve paresthesias, which resolved in the postoperative period. 1 patient had a flexor contracture, and 1 patient had a case of HO. And then comparing this to the 2 incision group, they actually only had 1 transient superficial radial nerve paresthesia at a complication rate of 10% compared to the 1 incision group. So ultimately, conclusions that can be drawn from this article is that there's relatively minor differences between the 2 discussed distal biceps repair techniques. In terms of recovery strength, it was slower with the single incision group relative to the 2 incision group. There was also fewer complications in the 2 incision technique compared to the 1, although the 2 incision group complication percent was much lower than data in the literature at the time. And just thinking of some potential limitations of the study, being that it could be low powered due to the sample size only being 19 patients and not a true randomized controlled trial.
Yeah, thanks, Matthew. Another good recap of that article. But you can see from this article, it seems like the dual incision would be kind of better based off of this paper. But like you mentioned, the big limitation is only 19 patients, and how much weight can you really put into 44% when it's 4 out of 9 patients? And I think that's the big limitation there. So moving on to our last article, we're looking at repair of the distal biceps tendon using suture anchors and an anterior approach. So again, this is another single incision approach by Lindner et al. In 1996. So getting into a lot of the background that we've already talked about. But so treatment options range anywhere from non-operative treatment to a non-anatomic repair using suture to biceps to brachialis. And then doing an anatomic repair with single, whether that be volar or dorsal, or dual incision. Like we kind of talked about, the now preferred one is anatomic repair. And again, mostly talking about whether we're using single or dual incisions. Because the literature, again, already showed worse outcomes with non-op and the non-anatomic repair. Overall, looking at some etiology, 3% of the biceps attachment injuries occur distally. 1% involve the short head, and 96% involve the long head. So these are mainly long head injuries, most often in a male on their dominant arm, and it's usually with an unanticipated heavy load to a flexed arm. So for those that were following along on the video version, I think Brad's article is the one that had the mechanism in there, and most of them, if you looked at it, and I know it was brief, but a lot of them were lifting something heavy or along that line. And again, a key finding physically will be weakness of supination and elbow flexion, but they usually do have full range of motion because of other muscles around the elbow. The study design for this one, again, a lot of these were smaller trials. So this one had 5 patients, so even smaller than the last one, which is why it didn't make it up higher in the list here. Distal biceps rupture, all men, they were aged 28 to 45. 2 on their dominant arm, 3 on their non-dominant arm, and anywhere from just over 2 years of follow-up, essentially. And essentially, this study design was describing an operative technique of the single incision for a distal biceps repair. Their operative technique, they used an axillary block with regional anesthesia. They used kind of the larger S-shaped volar incision over the antecubital fossa. They identified the lateral antebrachial cutaneous nerve and retracted that laterally, opened the biceps bursa, identified the stump, tagged that, and then they put 5 pounds of traction on there to kind of get it out to length. They said that this relaxed the muscle and then helped facilitate their repair. Then they identified their interval between brachioradialis, retracted that laterally, and pronator teres and retracted that medially. They did not release the radial attachment of supinator, and they did identify radial nerve and PIN and retracted those. And the radial tuberosity was then exposed with the forearm fully supinated. They decorticated that and put in 2 suture anchors with Ethibond. They only minimally debrided the stump and then sutured that with a locking stitch. They tensioned it in 90 degrees of flexion, full supination, and then they splinted that. Post-op protocol is pretty similar to Brad's and kind of what we mentioned before. So these are something that you usually need to immobilize, slow these patients down. This is a soft tissue procedure. So sutures in the splint were removed at 1 week post-op, which I thought was actually a little bit early. And then they were allowed to start passive range of motion only with their arm in full supination. Then they allowed them to do active triceps isometric exercises at 1 week. The posterior splint was stayed on when they weren't acting on active range of motion. And then they extended it 10 degrees every week for 6 weeks. And then at the 6-week mark, they allowed 60 degrees of flexion or 60 degrees of extension to full flexion. 8 weeks, they were allowed to start doing full range of motion. And then at 12 weeks, flexion and then supination strengthening. So really not starting the strengthening up until the 3-month mark. Results for them, average of 29 months of follow-up. All patients were satisfied. Again, this is an early study where we're not really quantifying things as much, but they did say that the repairs were clinically and functionally intact. And by 5 months post-operatively, all patients returned to their pre-injury activity level. 4 patients were employed as heavy laborers, requiring lifting of at least 90 pounds, what they noted in their paper. Full range of motion was achieved for 4 of the patients, and 1 patient had a lack of 5 degrees of full extension. So pretty close to full extension, definitely within the acceptable range of what's needed for a functioning elbow. They said that out of these 5 patients, they had no evidence of HO or change in position of their suture anchors, which obviously is something that you want in only 5 patients. Conclusions for them, the anatomic repair with a single volar incision can achieve satisfactory outcomes for distal biceps rupture, but limited exposure using suture anchors may decrease the risk of neurologic injury. Overall, they found decreased risk of HO and synostosis without the dorsal approach. Again, kind of tough to say with only 5 patients, but we did see some other papers that showed some pretty good results. Unfortunately, like I mentioned, Dr. Macfarlane and a few other people from the team weren't able to join us. So some further reading, if you guys would like to read on your own, that are good articles that I guess didn't make the cut this time. Repair of the ruptured distal biceps tendon, a systematic review. This one's actually out of Buffalo with 2 of our attendings here, Dr. DeQuinn and Dr. Bassan. So this is definitely a good read. And then the other one that we also just didn't make the cut, unfortunately, was distal biceps repair using cortical button fixation by Dr. Sethi. That's another one out of 2008. That's another good one to review. And then just to kind of close it off too, I'm not sure how many of these repairs Brad has seen or anyone else has seen. I personally have not seen any. But talking with one of our senior shoulder elbow faculty here, I know he described using the endo button technique to me. I'm not sure if anyone else on the call has seen any of these, and if they have, what's their experience and what the surgeons that they've seen have done.
Yeah, so I've seen a fair amount of these throughout residency so far, and I've only seen the single anterior incision endo button technique used. All three of the attendings who I've done these with all use the endo button tension slide technique. And just that single small anterior based incision kind of transversely across the antecubital fossa. But I think the big thing kind of take away from a lot of these early articles is it's like we've all said, it's hard to really do a comparison between any of the techniques, especially given how small the sample sizes were. I don't think you can really on the overall superiority of one technique compared to the other with sample sizes that small. And I think that that's why there's still a bit of a controversy today, and you still see people using both approaches because if both approaches, if you're doing it properly and as the original techniques are described, I think you can get good results with both, and it's going to take a higher powered study to really show a difference between the two if there is one.
Perfect. I think that's a great recap and a great way to end this session here. So thank you all for listening to another Citations Classic Shoulder and Elbow edition on distal biceps rupture.